Hello, my name is Ben Hannigan. I'm a Professor of Mental Health Nursing in the School of Healthcare Sciences at Cardiff University. And today, in this presentation for the Nightingale 2020 virtual conference, I'm going to talk about a recently completed evidence synthesis in the area of end-of-life care for people with severe mental illness. Just to say that a version of this presentation has also been delivered at the online International Mental Health Nursing Research Conference 2020. Here are the names of those of us who are part of the project team. Myself as Chief Investigator working in the School of Healthcare Sciences at Cardiff University. My Cardiff colleagues Paul Gill, Sally Anstey and Deborah Edwards. Deborah was Project Manager. Mann and Michael Coffey, who works at Swansea University, and Alan Meudell, who was part of the project team from the very beginning as a public and patient project member. One of the distinctive things about our evidence synthesis was the way in which we worked with an independent stakeholder advisory group, and we're very grateful to all the members of that group who gave of their time and their expertise to help us on our way. Particular thanks to Dr. Nikki Pease. Nikki is a consultant in palliative medicine at Velindre NHS Trust in South Wales. Nikki chaired our stakeholder advisory group, and particular thanks to Roger Pratt. Roger is named there at the bottom of this slide. Roger was really important as a public and patient representative in this project team. It was his conversations with my colleague Sally Anstey at Cardiff University that led to this study taking place in the first place. We know that not all deaths are equal, and that some people face what has been described as disadvantaged dying. We also know that people with severe mental illnesses such as schizophrenia or bipolar disorder have very significant comorbidities and experience higher mortalities and have reduced life expectancy when compared with the general population. And we also know that parity of esteem is a really important policy aim. This is the idea that people who are living with mental health difficulties should have access to the kinds of high quality healthcare services that are expected by people who live with physical health difficulties. And we aimed therefore to synthesize relevant research and other evidence, and I'll say a little bit more in a moment about what we meant by other evidence, relating specifically to end-of-life care to people with severe mental illness. And our purpose in doing this was to answer the question, what evidence is there relating to the organisation and provision and the receipt of care for people with severe mental illness who have an additional diagnosis of advanced incurable cancer and or end-stage lung, heart, renal or liver failure, and who are likely to die within the next 12 months. We published our project protocol in advance on the Prospero website, and we sought all relevant English language evidence that would help us to answer our question, and we looked for citations therefore that addressed the organisation of services, the provision and receipt of end-of-life care to people with severe mental illness, and we included 2 citations that reported directly on the experiences of people using services, the experiences of family members, and the experiences of staff providing end-of-life care to people with severe mental health problems. And we had a broad net that we cast over the evidence. We were certainly interested in pulling together quantitative and qualitative research, but perhaps unusually for an evidence synthesis, we also sought non-research material, including policies, guidelines from the UK, and reports from international practice initiatives and also clinical case studies. In our final report to our funder, the National Institute for Health Research, which is currently moving through the peer review and editorial system, we include a lot of detail of the methods that we used in this evidence synthesis, relating to how we searched databases, 10 in total, how we searched for non-research material using online searching methods, how we assessed citations for relevance, how we screened, how we appraised, and how we then extracted data from the material that we included, the research items and the case studies, and inserted those into tables. Once we had worked through this process of assessment for relevance, screening, appraisal and so on, we uploaded all included research items and case studies and relevant extracts from our policy and guidance documents into the qualitative data analysis software program NVivo 12, and having discussed our approach to our evidence synthesis with our stakeholder advisory group, we made the decision to conduct not one but two thematic syntheses. The first drawing on research, policy and guidance items, and the second evidence synthesis drawing on case studies. And in the case of the research items, we included in the first of these two completed thematic syntheses, we also produced an estimation of the confidence in our synthesized findings using grade and cirqual. Grading is the recommendations of assessment, development and evaluation, and cirqual is the confidence in the evidence from reviews of qualitative research approach, and both are useful in helping decision makers to weigh up the confidence that they ought to have in synthesized, summarized findings that are presented to them in evidence syntheses of this type. So what did we find? Well, having conducted a database and other types of searches, we began with almost 12,000 citations. Once we had reviewed those citations and decided what was in and what was out, we ended up with 104 publications included in our final two syntheses. So 34 of these 104 were research publications, 28 were non-research items, policy and guidance, for example, and 42 were case studies. And we synthesized the research, policy and guidance material using 4 themes, each with a series of sub-themes. Structure of the system, which addressed the shape and structure of the mental health and end-of-life care systems. We produced a theme which addressed professional issues, including the practice of mental health and end-of-life care professionals. We brought material together under a context of care theme that addressed the organisation, provision and receipt of care, and a final research and policy and guidance theme we termed living with severe mental illness. This addressed individual patients and social characteristics. And in our second synthesis, which brought together case study material, we produced 5 themes. One addressed diagnostic delay and overshadowing. The second, decisional capacity and the dilemmas of active versus passive treatments. Medical futility was our third case study theme, and our final 2 were individuals and their support networks and features of care provided. And I appreciate that this is a rather busy slide. What it does is to reproduce the summary figure that we have included in our final report to the NIHR. This, in a single figure, brings together all of our themes and our sub-themes, so you can at least get a flavour of the kind of detail that we found when we brought together the research and the policy and the guidance and the case study materials. So, for example, under the structure of the system theme, we included a sub-theme which addressed the idea that for people with severe mental illness at the end of life, there is often no right place to die. We addressed professional issues, and for example, we themed material which reported on end-of-life care for professionals doing mental health care, and conversely mental health professionals doing end-of-life care. And under, for example, our context of care theme, we had a number of sub-themes which address the interface between mental health and the end-of-life care system, and we had a sub-theme which addressed individual and family needs, taking into account items such as spiritual and psychosocial support, families and their involvement, advocacy, and so on. We then produced a series of synthesis summary statements, all associated with the research material included in the first of our two syntheses. And these synthesis summary statements were distributed across all four of our major themes, so that's structure of the system, professional issues, context of care, and living with severe mental illness. And of these 52 statements, 10 were statements in which decision makers might have a high degree of confidence, and this high degree of confidence was derived from the fact that the underpinning studies were all generally well conducted, they were relevant, and the studies also produced a high degree of coherence in terms of their findings. And we produced these 10 high confidence statements to inform our proposed implications for policy and services, and to inform our future research recommendations. If you remember just one slide from this presentation, then this is it. These are our headline implications for services and practice, and our recommendations for future research. So in terms of implications, first of all, formal and informal partnership opportunities should be taken across the whole of the system referring to the mental health and the end-of-life care systems, and ways through partnership should be found to support people to die where they choose. Staff caring for people with severe mental illness at the end of life need education, they need support and supervision, and that's both mental health staff who need supervision and education and support in caring for people at the end of life, and end of life care practitioners need education, support and supervision to provide care for people with severe mental illnesses. Services for people with severe mental illness at the end of life require a team approach, including advocacy, and we also suggest that timely provision of palliative care to people with severe mental illness requires, as a prerequisite, a proactive approach to physical health care. And our recommendations for future research, given that end-of-life care for people with severe mental illness looks to be a wide open area for investigation, is that we certainly need studies in the UK establishing factors both helping and hindering care, and we also need studies that co-produce and evaluate new ways of providing and or organising end-of-life care for people with severe mental illness. And in this final slide, it is important that we acknowledge our funder. So the MENLOC study was funded by the National Institute for Health Research, Health Services and Delivery Research Programme, and the views that I have expressed in this short presentation are those of us as authors and are not necessarily those of the NIHR or the Department of Health and Social Care. Thank you very much.